For example, something like this shouldn't hurt, but in someone experiencing neuropathic pain, this could be very, very painful. Um, can I? Yes. This type of pain occurs in about 17% of the general population. And there are a couple different causal factors that could be traumatic nerve injury, viral infection, vascular related, metabolic disorders. There's a couple different ways that you could end up with neuropathic pain. For the purposes of today, we are focusing on traumatic nerve injury slash compression and vascular related pain. So in neuropathic pain, there are a couple different ways that we can test for this in humans. One way is von Frey filaments, which are filaments of different tensile strengths. So think angel hair pasta versus spaghetti, for example. There's also a vibrometer, which tests vibration sensitivity, and thermode, which, as you can imagine, tests sensitivity to temperature. There are some available treatments that are proposed by the Neuropathic Pain Special Interest Group. That first line would include gabapentinoids, tricyclic depressants, SSRIs, and that would be if nothing in that particular line works, then you would go to the second line, which would be lidocaine, capsaicin, tramadol. And the third line, which doctors tend to avoid, are opioids and botulinum toxin A, for example. So for Formoterol, the big focus of today in terms of the drug that I'm using, as I mentioned, it is already FDA approved. It's used in the treatment of severe asthma and chronic obstructive pulmonary disease, and often almost exclusively given in combination with inhaled corticosteroids. It is meant to be a preventative, not a rescue. So this is the type of medication that you would take daily for extended periods of time. It is a long-lasting G protein coupled receptor agonist, specifically for the beta 2 adrenergic receptor. And because it is FDA approved and has been used for so many years and so extensively in patients, we have a list of side effects that are reported by these patients. These include, but are certainly not limited to, headache, anxiety, blurred vision, and muscle cramps. The reason why Formoterol is growing in popularity, not just for its intended purpose, but also for repurposing, is that it's shown some promising results in a couple different syndromes and disorders and injuries. These include traumatic brain injury, spinal cord injury, neuropathic pain in other models, Parkinson's disease, diabetic kidney disease, pain after cancer-related treatments, etc. The first half of this presentation is going to focus pretty heavily on spinal cord injury, and I am only presenting behavior data. So this is all published at this point, and there's a vast amount of molecular data as well. But I'm trying to get a lot done today. So the first half is just going to have behavior, and the second half is going to have some molecular work included because it's relevant to the behaviors that we did at the end of the study. So for SCI, about 300,000 people in the United States are experiencing spinal cord injuries in some fashion. The average age is 43, with the prevalence being higher in males than females. And the most common type of injury is a cervical spine injury. There are quite a few things that happen, quite a few mechanisms that are at play after this initial primary physical injury. The second most important thing is that secondary injury cascade. This includes a myriad of things like mitochondrial dysfunction, glial scar formation, oxidative stress, inflammatory reaction, etc. And there are pretty limited treatment options after SCI. One of the most commonly used one, which was methylprednisolone, well, I can't say it, actually ended up being more damaging to patients than they thought it would be and is no longer considered a treatment for SCI. So other than surgical intervention, there really isn't anything that we can offer these patients when they come in with an SCI. In terms of our model, we used 8-week-old female mice. I know I was talking about males, right? This happens more often in males. Well, we use female mice because after this particular type of injury, so we do the injury at the T11 vertebrae. So this is hind paw paralysis or hind limb paralysis that we're inducing in these mice, and they can no longer naturally express their bladders. So we have to be able to do it for them. In female mice, there's nothing in the way, and the survival rate's actually quite high. It's about 90 to 92%. In male mice, the prostate is directly in front of the bladder. And the survival rate for those surgeries in males is about 50% because very often, and these studies were done before I joined that lab, but very often, in an effort to express their bladders, they would actually pop their prostates and the mice would die. So we use females. Um, and then traditionally, when I started in this lab, they were using an 80 kilodyne impact of a force-controlled impactor-induced contusion model. For my studies, we were using a 60 kilodyne impact, and I'll explain why in the next slide. And we used a Basedow mouse scale score, which was a test of a score for locomotor capability. We took these measurements starting every other day, 24 hours post SCI, and a score of 0 would indicate complete hind limb paralysis. So after these surgeries, about 95 to 98%, obviously it changes with cohorts, were showing a score of 0, which is what we were hoping for. So after SCI, there are a lot of secondary consequences. These include a decreased quality in life and a decrease in average lifespan, as well as you would imagine, pain. So 80% of SCI patients report suffering from neuropathic pain, and 40% say that they would trade functional recovery for pain relief. That's kind of a huge number. So we were wondering, right, what's going on here? Like, what's the mechanism or what's the behaviors that we're seeing with pain? So very quickly, like I mentioned, we moved away from this 80 kilodyne model, and I'm going to explain what this means. So these are the control sham mice. So they were opened, but there was no laminectomy and actually the laminectomy was performed, but there was no contusion performed. These are the SCI plus formoterol treated mice, and these circles are the SCI plus vehicle. And what we saw was there was an increase in functional recovery as measured by the BMS score in these formoterol treated mice that was statistically significant from the vehicle treated mice. However, a score of 3, you can't see my body, but a score of 3 in these mice means that they can bring their hind paw flat next to their bodies. For the behavioral assays that I wanted to do, all of the mice needed to be able to bring their hind paws flat next to their bodies, not just the treatment group. As you can see here, these mice are underneath that threshold score. So we wouldn't have a control comparison. But in the 60 kilodyne model, we're still seeing that statistically significant increase in functional recovery in the formoterol treated mice. But now we're also seeing that our vehicle treated mice are able to surpass that threshold. So we decided, based on these data, to start testing our animals and the behavioral assays that I'm going to describe coming up, starting 3 weeks post SCI. But to be very clear, we started treatment with formoterol 8 hours post-injury. So treatment with formoterol or vehicle 8 hours post-injury. So everything that I'm describing, they are receiving drug once daily for the entirety of the study, whether it's formoterol or vehicle. I'm going to show videos of mice. They're not in distress. Just if you don't like them, I would recommend not watching, but they're not in distress. Okay, just throwing that out there. So this is the 60 kilodyne impact study. The mouse on the left received vehicle for 42 days, and the mouse on the right received formoterol for 42 days. And as I play these videos, I'd like to point out how they move their hind ends here. So there's a pretty significant difference in how these animals are moving. And so I wanted to know, right? We see these functional recovery. That's fantastic. Are we also seeing a mitigation of SCI-induced pain when we treat with formoterol? Because that'd be awesome, right? Functional recovery and pain relief. We started with looking at thermal hyperalgesia, so an increase in reaction to an already noxious stimulus. This is already annoying, right? We don't really want heat right underneath our hands or our feet. And to do this, we used Hargreaves, which is a test of withdrawal time. So the program records how long the heat is on before they remove their foot. An important note here is that we're not burning them and they can move whatever they want to, which is exhibited here, right? It's a small chamber, but right here in the center is where the heat comes from. So if they don't like it, they can go over here. We took baseline measurements before spinal cord injury, and we started taking these measurements 21 days post-injury, which is when we saw that the vehicle-treated mice were able to also place their hind paws flat. So this mouse, again, is just sitting there. She's grooming. And then, oh, she didn't like that. She picked up her foot and she looked at it. The reactions ranged. Sometimes they would just move out of the way. Sometimes they would stamp their foot, but the program records when they pick their foot up. The way to read this y-axis is that the lower on the y-axis is an increase in pain-like behavior, and as you go up, it's a decrease in pain-like behavior. And what we saw was that in the formoterol treated mice, there was a decrease in pain-like behaviors that was significant from the vehicle at weeks 5 and 6. That's awesome. So that was encouraging. We wanted to now look at another type of pain. We wanted to look at mechanical allodynia, which is a painful sensation to something that would not normally be painful. And to do this, we used the von Frey filaments. So again, everything was the same about how and when we did the assays. These filaments are applied for 5 seconds or until the animal moves their foot. So the 5 seconds is the maximum that we leave the filament applied, or if they remove it earlier, we don't do it again. And this is what that looks like. So you'll see on this foot, I'm placing it in the middle of the hind paw and there's no reaction. But as soon as I touched that, she didn't like that, she moved her foot. And that's the kind of reaction that we're looking for. And what we saw was that at week 3, when we started these behavior measurements, there was actually a complete reversal of the mechanical allodynia pain. So these formoterol treated mice were not experiencing pain-like symptoms, whereas the vehicle-treated mice were exhibiting these pain-like behaviors. So that's awesome. That's great. That was really encouraging. There's a lot of molecular work that went into this that I'm not showing today that also showed that there were changes in cytokine and chemokine expression and changes in the general pro-inflammatory pathway and protein expression for markers of injury and things like that, which is all published if you guys ever are interested in looking at it. It's just a lot. So recently, I finished this study here. I wanted to know, we see these changes, these positive changes in the SCI model. Would we see positive changes in a different type of nerve model? So I looked at the partial sciatic nerve ligation model. For this, I used 13-week-old mice, and the model consists of opening. So the sciatic nerve runs along your femur. And so this model consists of opening and exposing the nerve and putting a suture through the center of it and tying a knot. And this creates a model that has a mix of injured and intact fibers and is a pretty good mimic for the human symptoms of like spontaneous pain and sensory changes. So baseline measurements were taken before the PSNL. We have to give them 7 days to recover before we start anything with them. Because remember, they do have an incision this time. They have staples this time. So we have to give them that recovery time. And then we were taking measurements. So I took the post-surgery baseline and then started giving them formoterol or vehicle, and then took the post-drug measurements 3 days, 7 days, and 14 days post. So this study is much shorter than the SCI study that went all the way out to 6 weeks. You already saw this video. I'm going to go through it. And what I found was that by day 14, the formoterol treated mice had almost completely returned to their pre-surgery baseline, and they were no longer significant from the sham controls. So I have a sham vehicle control and a sham formoterol control, and there was no difference here. However, the PSNL plus vehicle treated mice were statistically significant from all 3 of the other conditions, which is really encouraging. That's as far as I've gotten with this. There's more to do. So moving on to headache. So we see all these positive changes with treatment with formoterol. And that's fantastic. It would be great to apply that in a human setting. That'd be great for the patient. But we already know that there are certain side effects that come along with treatment with formoterol. So wouldn't it be spiffy if we could also offer, if this patient starts to experience these side effects, if we had something ready to give them to mitigate what they're experiencing? So the first part of that was to assess whether in our model, formoterol was inducing periorbital allodynia or sensitivity in this area right here on their foreheads, like you can see in the picture. This is a short video of how I was doing that. You'll see this mouse does not care about the application of the filament. And the second mouse, in fact, does quite care, does not like that, just trying to get it off her face. So that's the kind of reactions that we were looking for. And what we saw was as soon as we started taking measurements 7 days post drug initiation, because these are all surgically naive, so they were only receiving drug. Uh, all of the Other than day 14, all of the mice were experiencing or exhibiting periorbital allodynia-like behavior. So formoterol is inducing periorbital allodynia in these mice. So then I was curious to know, is it doing other stuff? What else could it be? What else could be a comorbidity going along with this? So headache and migraine have quite a few comorbidities. And it might have taken out too much, but that's okay. Just for today, we're focusing on light sensitivity. I also tested anxiety and brain fog, but I took those out. So the way that we tested this was we used light dark boxes. Again, baseline measurements were taken prior to drug administration. There was no surgery involved here, so there was no impact on movement. The test was 30 minutes long, and we tested 6 different luxes, so 6 different light intensities. We also kept the chambers consistent because we did see some changes or some differences in lux values between the chambers. So we made sure that if mouse 1 was in box 1, it stayed in box 1 for the entire 6-week study. And this is what that looks like. So as you can see, the mouse again has free range. She can choose to go wherever she wants to go. And then during the actual study, this would be covered as a transition area, and then this would be covered as the dark area, and the light comes from here. And what we found was that we did this for 6 weeks, so there were no changes up until the 28-day time point, where we saw that the formoterol treated mice were spending less time in the light at 3 different luxes, and then on day 35 at 2 different luxes, and then on day 42 at 4 different luxes. The one that remains the most consistent is 107.7 lux, which is about room, like normal light. So that was really interesting to us. The next step that we wanted to do was look at the mechanism behind this, try to pinpoint maybe what could be going on. So we have these behavior data. We see that formoterol is inducing these behaviors or causing these behaviors in this medication overuse model. So what could it be doing in the brain? So there are a couple different brain regions of interest in headache and migraine. For today, we're focusing just on the periaqueductal gray. So the first thing to do for this was to make sure that the receptor for the drug was actually in the PAG. It wouldn't make sense to look at a tissue where the drug can't even have an impact. And formoterol does cross the blood-brain barrier. So I looked at the relative protein expression of the ADRB2, the beta-2 adrenergic receptor, and found that yes, it's present in the PAG. Fantastic. I wanted to look to see if there was any crosstalk between the adrenergic receptor, the drug, and the endogenous cannabinoid system. So the beta-2 is found throughout the body in different concentrations. It's in the lungs and it's in the heart, and it does a variety of different things. But one of the hallmarks of it is it is not involved in headache processes. So I wanted to see if perhaps, like I said, there was this crosstalk because the cannabinoid receptors are also GPCRs, and they are involved in headache, as well as, again, as always, a variety of other different things. So to do that, just quick overview. There are 2 main endogenous cannabinoids, 2-arachidonoglycerol, which I'm going to call 2-AG, and anandamide, which I'm going to call AEA, which are also found in different concentrations throughout the body, but I tested for both. Another important thing that we had to consider was that we were starting this study, like we were collecting tissue 7 days post-drug initiation when the mice were 9 weeks old. But we were finishing the study and collecting more tissue when they were 15 weeks old, which doesn't really seem like it's only 6 weeks. What difference does it make? but their lifespans are so much shorter that it's actually a pretty large difference in their life cycle at that point. So we wanted to assess via liquid chromatography, mass spectrometry, if there was a difference, just an innate difference in naive mice in the levels of AEA and 2AG based on age. And we saw that there were. There's an increase, a significant increase in the levels of AEA in the 15-week-old mice versus the 9-week-old mice. However, in 2AG, that is reversed. There's a significant decrease in 2AG levels in the 15-week-old mice. So then we said, well, we better look at the receptor. So looking at cannabinoid receptor 1 protein expression, we saw a significant increase in protein expression in these 15-week-old naive mice versus the 9-week-old. And as expected, there was no difference in the ADRB2 at any time point. So what this told us was for all of the molecular work that we were doing, we needed to compare the data from 15-week-old test mice to the 15-week-old naive mice, and the same for 9-week versus 9-week-old naive. It wouldn't make sense to compare the 9-week-old drug mice to the 15-week-old naive mice. So we started with looking again using LCMS at levels of AEA and 2AG. And what we found was that in the formoterol treated mice, there was a significant decrease in the levels of AEA at 7 days, but an increase at the 6-week time point in the formoterol treated mice. Then we looked at 2AG, and again, we saw a significant decrease in the levels of 2AG after 7 days of treatment with formoterol. And by the 6-week time point, there was no significant difference. Looking at protein expression, we saw at both the 7-day and 6-week time points, there was a decrease in the relative protein expression of the CB1 in the mice that received formoterol versus the vehicle-treated mice. And in theory, there really shouldn't be a reason for that because, again, this drug is hitting the beta-2 adrenergic receptor. It's not known to hit the cannabinoid receptor. That really shouldn't be a thing here. So that was really interesting to us. So we decided, based on those data, to inhibit the enzymes that are involved in 2-AG and AEA. So the enzymes are MAGL and FA, and we used the inhibitors called MJN and J&J. And then we also used a CB receptor targeting agent called WIN to kind of bind and block that receptor. So for this study, all of these mice received formoterol. I know it says vehicle, and that's because the vehicle treatment refers to what these two compounds were made up in. So all mice received formoterol. So we can see here, pre-baseline, they received drug, and at the 7 days, they're all experiencing these headache-like behaviors. They received 1 injection of either of these two compounds, and I took behavior measurements for 4 hours. And what we saw was that at 1 hour post-injury, the CB targeting agent, as well as the enzyme inhibitors, the mice that received these treatments saw a complete reversal in the headache-like behaviors, which is pretty crazy because that suggests that formoterol is interacting with that system in some way, right? So then we looked at the 6-week time point. So here we only treated with the CB receptor targeting agent as informed by the LCMS that I showed you on the previous slides. And we saw that as soon as 30 minutes post injection, there was, again, a significant reversal of the periorbital-like behavior. And then by 2 hours post, they were back to their pre-injection baseline. So that really heavily suggests that in some way, formoterol is involved in something that has to do with the endogenous cannabinoid system that's inducing this medication overuse headache. Or maybe it's not that linear. Maybe they're both existing. Like something is going on with a completely different receptor system. So as a very brief overview, we saw that at the 7-day time point in the mice that received formoterol, there was a decrease in the levels of AEA, a decrease in the levels of 2-AG, and a decrease in cannabinoid receptor 1 protein expression, resulting in pain. At the 42-day time point, there was an increase in AEA, a decrease in the cannabinoid receptor protein expression, and again, we observed these pain-like behaviors. But when we started to target different aspects of the endogenous cannabinoid system, we were able to reverse these pain-like behaviors at both time points. Excuse me. And this was also very interesting. So AEA on its own is also known to induce headache. So this could also explain what's going on at the 42-day time point. Very interesting to me. So in terms of future directions, this slide hasn't changed from when I graduated 2 years ago. So my collaborator is working on the SCI project. She is using um, GFAP knockout mice. So we are targeting the beta 2 adrenergic receptor on astrocytes to see if there's a difference because of the whole glial scar thing. I didn't show any of that, but there's a huge involvement there. And then I am still doing this project, but I'm interested in looking at how changes in the endogenous cannabinoids in this model may or may not be involved with changes in mitochondrial function and protein expression. And I'm also looking at Formoterol with the PSNL, like I showed you guys in that one slide that's just started. And I'm going to be looking at it with TBI as well. Because if this would be like the basis of a drug-based grant, right? Like we're seeing all these different changes, but we don't know the mechanism. We really don't know the mechanism behind it. There are some groups that have used Formoterol looking at TBI and they've not seen any changes, but they're looking at it in TBI stroke models. So I'm going to do a very short study again, looking at TBI and using the type of model that we use, which is mild TBI. And that's it. Are there any questions?
Thank you, Ingrid. I actually did have a question. I was wondering if you could tell us what happened with anxiety. I'm really curious about that.
Sure. Let's see if I deleted the slide or if I left it in and just hit it. Oh God, what's happening? Continue to share. Um, so nothing happened is the shortest answer. So we use the elevated plus maze for this. This arm is open, so there's no walls. And can you see what I'm talking about? Okay, good. And this arm is closed, so it has walls. What one would assume, which also aligns with the data, is that when they are experiencing anxiety-like behaviors, they hide. They would hide in these arms with walls. But we didn't see that. There was actually no difference over the course of 42 days in time spent in the closed arm and the open arm that was significant. You can see that it looks like there's a trend here, but it still wouldn't be the trend you would expect. Um, but for Motorol, so the beta adrenergic receptors, for Motorol is kind of almost like a mild norepinephrine. And so it's also associated with hyperactivity. So this actually kind of would fall in line with hyperactivity. But because we didn't see anything significant here and there was so much going on, we just kept going. We didn't pursue this further. Let's see if I left any of the molecular stuff in here. I did. Did I? Yes. So we focused on this instead, which was looking at the cytokine and chemokine changes over time, and lesion volume over time. Scrolling all the way back down. We also looked at these at novel object and rotarod. There was no significant difference in anything we did here. And with the novel object, the formoterol treated mice spent more time with the novel object, which was not what we were expecting either. I'm not really sure what I'm showing you. I don't remember what. Oh yeah, this is open field irrelevant. What is this? The formoterol treated mice didn't move as much, but they spent more time with the novel object, which is not what you would really expect either, which is kind of, we hypothesize speaking more towards the hyperactivity aspect of the drug.
Yeah, I wonder because when I look at that, it seems like perhaps a change in ability to learn.
Hmm.
Um, the same thing with the EPM, where it looked like the vehicle animals were slightly changing their behavior over time. They were learning, whereas
Hmm.
the hormonal ones just didn't. But
Yeah.
that's
Yeah.
interesting.
And there was a question of like risk-taking behaviors and things like that. Um, in a perfect world, I would have been able to do it all, but we wanted to defend. I wanted to defend, and so I didn't do it all. But this is published though. Like this is it's not like I gave up halfway through. There was no giving up. It was just like we need to refocus. on exactly what I was asking instead of just, you know, doing it all. Yeah, it was very interesting. I still think this is interesting. Um, I haven't done this with the PSNL. I mean, I showed you guys what I've done with the PSNL group. I've done one thing, one type of assay. So I'm hoping to do more and see how that changes because this is pretty close to what the other Formoterol data looked like. So, any other questions?
I have a quick question, and if it's like a little dumb, I apologize.
No.
But I know that you guys, or that you mentioned that you haven't fully like figured out how what is it, formoterol is working like mechanistically. But do you have an idea of whether it's like rescuing mechanisms that were damaged or dysfunctional because of injury, or is it blocking like pain sensation or pain sensors in a sense?
So we think that it has to do with mitochondrial biogenesis. I think I took all that out. We think it has to do with mitochondrial biogenesis. So mitochondria play a lot of really, really important roles in recovery and in injury processes. And after spinal cord injury, they pretty much they can't keep up with the level of injury. And so we heavily believe that what formoterol is doing is mediated through mitochondrial biogenesis. I will show you. Can you guys still see my screen? Can you
Yeah,
see?
yeah.
Okay, you can see the new PowerPoint I brought up.
Yes.
Okay. So the other lab, what they were doing is they were looking at markers of mitochondrial biogenesis and mitochondria in general. So PGC1 alpha is the master regulator of mitochondrial biogenesis. And it actually, so when we were treating with formoterol after spinal cord injury, there was a significant increase in relative protein expression of PGC1 alpha. So we think that that is kind of a rescue mechanism.
Mm, interesting.
And then there was a trend. I think I might actually have this is
This is a
what is
little bit out of left field, Ingrid, but I did a deep dive a few years ago on how hibernation works. And the whole like torpor arousal cycle, it's crazy. Animals will have like a 200-fold change in their heart rate during this, but that entire process is all mediated by PGC1 alpha.
that's crazy.
Yeah, it's
Yeah,
nuts.
that's awesome. It's a cool it so everyone's studying mitochondrial biogenesis. People have never questioned the importance of mitochondria, but we're starting to look at it in different contexts and throughout the different stages of injury and things like that. Because, for example, in your brain when you have so a headache is changes in like cortical spreading depression, for example, is changes in the brain that would affect astrocytes. Astrocytes are really, really important when it comes to crosstalk between neurons and blood vessels and everything. And one of the primary things that astrocytes do is calcium signaling. Mitochondria take up calcium. And in times of injury, they take up a lot more calcium. And what usually ends up killing the astrocyte is that the mitochondria can no longer manage how much calcium they're taking up. And so it's mitochondria are in everything. Like their importance is profound. It's really cool.
So then I kind of have a follow-up question. Is it then the loss of the mitochondria because of that injury that's causing pain or this like dysfunctional mechanism?
Um, we don't know. We do
Mm,
know that along with the injury and the deficits that come with the injury, we have mitochondrial dysfunction.
hmm.
Whether it's causal or correlated, we're still investigating. And when I say we, I don't mean just our group. I mean like a lot of like all the groups. Well, not maybe not all the groups, but the groups that are interested in that particular part of injury. That's what we're investigating.
Okay. Thank you.
Mhm. Mhm.
I had another question. I was wondering about why, I mean, I don't know anything about this, but why are we seeing actual changes in endocannabinoid levels in the PAG just associated with age? Is it part of neurodevelopment or is that part of developing like old age and disease that leads to bad things.
So endogenous cannabinoids, like I said, they have a lot of different roles. They play roles in non-negative aging. So in the way that your brain matures over time, and they are heavily impacted by body stress and by other outside factors. So one of the cannabinoids are really involved in obesity. Another cannabinoid is really involved in, oh my God, like literally everything. I'm not exaggerating. Like they're like fertility. So it would make sense that especially something like fertility, which is cyclical and fluctuates, that these also would fluctuate. I would be really curious to bring mice that are a little bit younger and a little bit older and just collecting them and seeing if we can kind of track, if it is cyclical, if we can kind of track these changes over time. Because that'd be a really interesting basis of things to look at.
Yeah, I wonder about if we could take some uh, pre-menopausal versus post-menopausal, right? Like cycling versus non-cycling animals and see how that changes over the course of that process. I know we're starting to explore the role of hormones with endocannabinoid signaling in the PAG, but it's a little confusing, and that could be a way of getting a baseline understanding of what's
Absolutely.
happening.
Especially, so we used females in the headache model because we were using them in the spinal cord injury model, right? But also headache is more prevalent in females. And it's pretty agreed upon that is also heavily impacted by hormones. So if hormones in the endogenous cannabinoid system are fluctuating or working together, that would be a really if we can pinpoint the mechanism and how we can modulate that mechanism to change headache treatments, that'd be fascinating, as well as other types of things as well, not just headache, but any other questions? No? Okay, cool. We can be done.
Thank you, Ingrid. That was really interesting.
Thank you. Thank you for inviting me back.
Anytime. All right. Bye,
Bye.
guys.